So in males, so what are the diagnoses we can do, ma'am? Like what are the problems as a fertility we can see, like azoospermia or some other causes? Like what are the diseases we can see in men's, ma'am?
Okay. So basically, in men, what we do, the single important test is semen analysis. So in semen analysis, there are various parameters that we check. First of all, what is the color of the semen? How much is the volume of the semen? If fructose is present or absent. Then we come to the count. What is the sperm count per ml? What is the motility of the sperm, that is how fast they are moving. So there are grades of motility, 4 grades are there. So we need a grade which is the fast moving sperms. So what is the percentage of fast moving sperms? Then we look at the morphology, means how is the structure of the sperm, how is the head of the sperm, body and tail, or if all the three are normal. So that is the structure of the sperm. So all these are different parameters that are checked at semen analysis. So normal sperm count, up till few years ago, there is a WHO guideline which says how much should be the normal sperm count. Up to few years ago, it was 40 millions and above. But because all over the world the sperm count is decreasing, so and they have found that, like, again, the male who are able to have their own children naturally, so based on these two things, they have reduced this count to 15 million. So now we considered as 15 million as the minimum, like normal sperm count. So those who have sperm count number less than 15 million, we call it as oligospermia. So oligospermia also, there might be severe oligospermia when we see the number is less than 5 million. So severe maybe if it is oligospermia, the patients may still have option of going for IUI. But if it is severe oligospermia, like less than 5 million, then you have to consider IVF, because this much count we have to make the sperms, actually to select the sperms in IVF and make the embryos. So severe oligospermia requires IVF. So less than 5 millions. Then if we see the sperm count less than 1 million, wherein we have to actually screen the slide a lot, then they call it cryptospermia, means hidden sperm. They have to search for the sperms. Then it comes to 0. So then when it is 0, there's no sperms in the semen sample, then it is called azoospermia. So this is based on the number of sperms. Then coming to the motility. So as I said, there are grades of motility. So if the motile sperms are like good number, like 32% or more than 30% motile sperms which are fast progressive, then it is considered normal. So motility, if it is less than 30%, then we call it asthenospermia, means this problem with the motility. It's called asthenospermia. Then coming to the morphology, that is the structure of the sperm, if it is normal or not. So abnormal structure of the sperm, we call it teratospermia. So there are different terminologies what we use: azoospermia, asthenospermia, oligospermia, teratospermia, and there can be combinations of all these. So these combinations can be either less sperm count along with less motility. So it is oligoasthenospermia. If it is less count with abnormal sperms, then it is called oligoteratospermia. So these are the different terminologies what we use. Then why these happens? So there might be multiple reasons why this happens. So if we consider azoospermia, that is 0 sperms, there can be problem either with the production of the sperms, or there can be a problem wherein the sperms are getting produced in the testes, but there is a obstruction in the path where it is coming out. So then it is divided into two: obstructive azoospermia, non-obstructive azoospermia. So obstructive azoospermia, we may still get the sperm because they are getting produced. Non-obstructive means there might not be any obstruction, but still if the sperms are not there, means there might be problem with the production of the sperms. So based on the hormone levels, based on the ultrasound report, based ultrasound of the scrotum, wherein they will check the testicular volumes, they will look for the hydrocele or varicocele, that is the swellings in the area of the scrotum, and the semen analysis. All these together, we can come to a conclusion that if it is obstructive azoospermia and clinical examination, or non-obstructive azoospermia. So based on that, the patients are accordingly either given some hormonal treatment so that we can have at least few sperms to use in IVF. So azoospermia usually will need treatment only with IVF, because the sperm count is 0, and if we have to take the sperm from the testes, then those sperms are immature sperms and less in number, so we have to use only for ICSI in IVF. So for azoospermia, the treatments usually are related to IVF, either through testicular aspiration of sperms or epididymal aspiration of sperms, or after hormonal treatment, again the same procedure, testicular aspiration and IVF. So why azoospermia happens? So basically it can be either because of some obstruction, congenital absent vas, they say, that outflow tract, there might be absence of that tube which carries the sperms. So it is bilateral congenital absence of vas. So both sides, that tube is absent which carries the sperm. Or there can be problems related to hormones, or there can be some genetic problems, or there can be some infections which have affected the testes, like childhood mumps or tuberculosis or filariasis, which has affected the testes, which can also cause this azoospermia. Then other things like oligospermia, the less number. So there are multiple reasons for less number. There can be because of diabetes also, the sperm count motility gets affected. Thyroid issues, smoking, drinking, which we already discussed. All these can cause oligospermia. Even some genetic problems can cause oligospermia, that is the less number of sperms. Then coming to the morphology. So morphology is also affected by many things like smoking, drinking, lifestyle, other like diabetes and all, any infections, that can also affect the morphology. So all these issues we have to see, hormones sometimes ultrasound of the scrotum, clinical examination, to come to the conclusion. So what is causing the issue? So accordingly we can decide the treatment.